can't emit beta or they can't emit alpha, so they can't be used for therapy. Whereas the other ones which you see here, actinium and radium, they emit only alpha particles, so they can be used only for therapeutic purpose only. So most common theranostic tests which were used in nuclear medicine currently are 123 sodium iodide or 131 sodium iodide, which can be used for thyroid cancer and hyperthyroidism. MIBC, as I told you, it can be tagged with 123 or 131, which can be used in neuroblastomas, pheochromocytomas, and paragangliomas. And this technetium nitrogen metronate or sodium fluoride PET, which is used in diagnostic, and it can be tagged with the radium 223 for therapeutic purposes. It's called bone pain palliation, prostate cancer, and gallium DOTA based reagents and lutetium dotatate. So if you see, this DOTA is same here. This octreotide, the both are same. DOTA based octreotide, here lutetium based octreotide. Both are SSTR targeting and neuroendocrine tumors. Gallium PSMA, PSMA, and tagged with lutetium 177 or actinium 177. The target is PSMA and used in prostate cancer cells. And one more theranostic pair is technetium in tear, like in hepatocellular carcinomas or metastatic colorectal carcinomas. Diagnostic imaging use this technetium labeled MA, whereas therapeutic it is yttrium 90 microspheres. So if you use if you use the same molecule for diagnosis as well as therapy, like this iodine 131 and lutetium 177, that's called pure theranostic approach. Whereas if you use sodium iodide 123 and 131, or gallium based octreotide and lutetium based octreotide, or gallium based PSMA, lutetium based PSMA, in this PSMA is same, but the other molecule which emitting radiation is different. So lutetium 177 for therapeutic and gallium 68 for diagnostic approach. This radionuclide is different. This is called hybrid approach, in which PSMA is the molecule which has physiological effect in the body. So PSMA decides what has to happen inside the body. It's not lutetium 177. It only helps in targeting the molecule and cell kill. So this is called hybrid approach. So coming to in this, it's been already I've been informed that thyroid cancer has been already discussed. So I'll be more focusing on bone pain palliation, DOTA therapies, and PSMA therapies, and TARE. So in case of bone pain palliation theranostics, as I already told, the diagnostic molecule which has been used are technetium labeled MDPs, HTPs, or sodium iodide PET. Whereas therapeutic it is radium 223 or samarium or lutetium HTPs. So this is a modified WHO pain ladder, in which when there is a minimum pain, there is use of non-opioid analgesics, and if there is excessive pain or not treated by non-opioid analgesics, so weak opioids can be given. And in case of step 3, when there is intractable pain, strong opioids can be given. And when in case of step 4, other interventional treatments can be given, in which our bone pain palliation can come in step 3 and step 4, where intractable pain is there, and ours also as adjuvant. So currently, bone pain palliation is approved for metastatic painful bone lesions with osteoblastic response, as confirmed by areas of intense uptake on radionuclide bone scan. So if you see, this is MDP bone scan, and right side one is sodium iodide, sodium fluoride PET bone scan. So this intense uptake in the vertebrae, ribs, and bilateral humerus, and everything is it's showing very high uptake. So this high uptake is based on this osteoblastic response, in which newer bone formation will be happening, and this MDP targets that newer bone matrix, as well as sodium fluoride PET targets that newer bone matrix. So the uptake is shown properly. So currently, this bone pain palliation approved in this osteoblastic metastasis only, and other contraindications is because it is involving significantly marrow, when compromised hematological functions with hemoglobin less than 8 or complete WBC counts of less than 3,500 or platelet counts less than 1.5 lakhs. This is contraindication, bone pain palliation. Or when patient is having significant reduced renal function, this because unused medicine is excreted through kidneys. So if there is a significant renal function, there will be uh, the, the medicine what we give is inside the body and it keep on emitting more and more radiation and it can cause significant other side effects. And when life expectancy is less than 3 months, it is also contraindication because it is not going to help much. These are the common radioisotopes which are currently used in bone pain palliation. If you see samarium 153 and rhenium 188 and lutetium, these are the most common ones are used. Whereas currently radium 223 is not available in India, but worldwide it is available and is being used. And studies has proved the efficacy of radium 223 as well as samarium 115, lutetium 177, HCDP, EDTM. NCCN guidelines for management of MCRPC showed the radium chloride used in here, like if you see in the end, the chemotherapy naive symptomatic patients who have bone metastasis, docetaxel as well as radium chloride is advised according to NCC guidelines. Or if there is any docetaxel failure, then radium chloride can be given for bone metastasis. So these are the published studies on radium-223 dichloride in patients with castration-resistant prostate cancer and symptomatic bone metastasis with or without previous docetaxel use. This is one of the landmark study which this is one of the landmark study which showed patients in which exhausted chemotherapy has been like this radium-223 dichloride has been used and in these patients there are significant symptomatic bone metastasis with known visceral metastasis. And standard of care, when compared with standard of care, there is a significant interval in significant reduction in pain symptoms observed. So this is, as I told you, this is a landmark study which has it's also called alpha-syncotype alpha-synaptic in prostate cancer trial. So in this, 921 patients have been enrolled and a 2:1 ratio. In 614 patients, it has been given alpha-synuclein, whereas 307 patients have been taken for only placebo. Significant reduction in SSR is skeletal-related events has been observed, as well as significant improvement in pain has been observed in these cases. And median overall survival in radium actually there is one more sub-analysis in this, in which patients who have already received docetaxel or patients who has not received docetaxel, they have observed the median overall survival, in which significant median overall survival has been observed in radium 223 who has not received any dose of placebo, which is 16.1 compared to placebo, which is 11.5 months. In case of previous docetaxel use also, although it is statistically significant of 3 month median overall survival increase. Other secondary endpoints is time to first symptomatic skeletal event has significantly prolonged in Alzheimer's. As I told you, other radionuclides which is commonly used in India are samarium 153 and lutetium 177, and these are several studies which has been published. Samarium 173 lexidronam for palliation of bone pain associated with metastasis. So this is a theranostic which I was telling. So left side, if you see the technetium 99 labeled HMDP, which shows where all that cancer cell has been there, and bone scan shows this. And same target we use with lutetium 173 samarium or lutetium 177 EDT. So this HMDP or EDTP are bone matrix seeking agents. So other one, as I told, lutetium 177 EDTMP for treatment of bone pain metastasis in disseminated skeletal metastasis. This study has been published, which showed significant reduction in pain in these cases. one more, which is AIM study in which lutetium DOTA has been used for bone pain palliation, and this also showed significant increase in overall survival as well as quality of life in these patients. And coming to PSMA theranostics, so PSMA, where in the treatment of prostate cancer it comes. So even the prostate is clinically localized disease, only radiation or radical prostatectomy along with active surveillance can be there. And in case of non-metastatic, metastatic HSPCs, non-metastatic CRPCs, our PSMA theranostic may not come. But when it is metastatic and CRPC, these are the approved modalities by FDA. Along with, if you see, there is only radium-223. This chart was before 2022. Till that time, only radium-223 was approved for metastatic CRPC. Whereas currently, it has been approved. Lutetium-177 PSMA has been approved. As I told you, PSMA is a cell surface glycoprotein, which has the 70 amino acids, which has a short intracellular portion and transmembrane portion and large extracellular portion, which can be targeted. So normal PSMA expression can happen in PSMA epithelium, whereas this PSMA and PSM ratio has significantly increases in PSMA cancer cells. So in this case, what happens is there is like multiplication of this PSMA protein over the cancer cells around 1,000 times more, and we see more of prostate tumors, more of prostate PSMA PSM ratios. So this targeting of PSMA we can target all three areas. So intracellular portion, transmembrane portion, as well as extracellular portion. Intracellular portion targeting will be difficult because only after cell kill we can see the intracellular portion. The most common thing which we target is extracellular portion, and it can be targeted by either monoclonal antibodies, aptamers, or small molecule antigens. And the most common one which we use are small molecule antigens. So if you see on the right side, gallium PSM11, PSMA INT, 18F DCFBC, DCFPIL, or 18F PSMA. All these are targeting one substrate which is extracellular. Because it is easy to target extracellular, so even without cell kill, we can target directly this. So if you are listening any of the current PSMA things, those are all targeting only extracellular portions. This diagram summarizes what happens in either gallium PSMA or lutetium PSMA. So in case of lutetium PSMA, there is a prostate cancer cells in which this blue thing is the PSMA molecule as the transmembrane protein. And this transmembrane protein is targeted by this PSMA 617, which has been attached to the radioactive substance called lutetium 177. So once the both attaches, there is endocytosis of the molecule, complete molecule, in which 177 lutetium keeps on emitting beta rays, and there will be cell kill. The same goes with actinium PSMA also, in which actinium is the only thing targeted over here to PSMA. When it internalizes and it emits alpha rays, there is more DNA damage. In case of beta emitting radiopharmaceuticals, it is you can consider 1:100. So 1 cell kill in beta, 200 cell kill in alpha. So this is one more land trial for lutetium PSMA 617, which has been published in 2018. It's called Loop PSMA trial, in which they showed a significant overall survival. And the main endpoint was PSA response. So PSMA of 100 has gone less than 50. So 50% decline in PSA was considered as PSA response. Along with that, the other endpoints were toxicity testing, in which primary endpoint around 57% cases, they achieved PSA decline of more than 50% or more. This is, as I told you, this is beta therapy. So if you see beta therapy, there is around 57% success rate of PSMA decline of more than 50. And objective response is more in case of nodal or visceral disease, which is reported in around 82% of cases. So in case of visceral disease, this Alsinca trial excludes the patients with visceral disease, whereas lutetium PSMA can be given in patients with visceral disease. So this is AIMS New Delhi study in which they have used lutetium DKFZ PSMA 6. So in this, if you see lutetium 177 is the radionuclide which emits beta rays. DKFZ is the linker molecule. PSM is the target protein which goes and attaches to PSMA transmembrane protein on cancer cell. So the therapy in metastatic castration prostate cancer and safety, efficacy, and quality of life assessment using these things, in which there 31 patients has been treated with when the initial study was published in 2019. 31 patients have been 31 patients have been treated, in which we have got complete responses also. So these two cases, if you see, 2 out of 31 cases has complete responses. So these two had less tumor burden with only visceral metastasis and oligo bone metastatic. And other cases like 20 out of 31 had partial responses, which is around 65% of cases, just above the average of 50% which has been published in the previous study. In these, in whichever cases have progressive disease, 6 out of 31 cases have excessive tumor burden with involvement of almost all the bones. And so metabolic response has been observed by gallium-6 scans, in which 2 out of these cases, like only out of 6 cases could be assessed with this metabolic response. So out of these 6 cases, these 2 had complete response, which has been the same cases of these 2 which had biochemical response, and other ones had partial response. 3 out of 6 cases and 1 out of 6 has stable disease. So clinical response, along with other clinical responses, VAS score has significantly reduced, analytic score has reduced, because there is cell kill. Along with cell kill, there will be reduction in pain, amount of pain, and the quality of life has significantly improved. This is our own AstraZeneca Institute of Oncology case, in which there was significant. If you see, there was a significant prostate involvement as well as lymph nodes and multiple bones. So this patient had presented in October 2022, and this is a gallium scan. So this gallium scan had shown there is a progression of disease compared to previous gallium scans, and the PSA level was 81 with almost involvement of multiple bones. And initially, after giving first cycle of lutetium PSMA, there is like drop of PSA to 42 nanograms. So almost with the first cycle itself, we could achieve that 50% PSA response. And after the second PSMA, there is a significant drop of PSA to 3 nanogram. And 2 months after the second PSMA, we did gallium PSMA scan to assess the disease extent. So you could see there is almost complete resolution of all the lesions which has been shown on the first scan, whereas only negligible amount is there, a negligible amount of pressure uptake is in the prostate region. So since this patient is a 94-year-old individual, we had stopped based on a good response to 2 cycles of PSMA therapy. We had stopped lutetium PSMA therapy, and currently he is under observation. And there are several other clinical trials which has been enlisted. So out of this therapy trial and loop PSMA trial and visual trial has already been published, which showed a significant overall survival as well as progression-free survival compared to normal. So, as I told you, these PSMA theranostics contain lutetium PSMA or actinium PSMA, based on which beta emitting or alpha emitting substance has been used. So actinium PSMA then can be used in patients who are like this. This can be used in patients who has already received lutetium PSMA therapy and proved unresponsive to that lutetium PSMA therapy. So as I told you, in gamma around 45 to 50% of in beta and lutetium PSMA, only 45 to 50% of patients are biochemically responded to PSMA ligands. Whereas in actinium it is around 20% more. So this is one of the first case published who has received actinium PSMA, in which if you see the left side, PSA level of 2923 and diffuse involvement of almost all the bones, in which PSMA, like lutetium PSMA is contraindicated because there is significant involvement of bone and hematological dysfunction itself. But in this patient, when he has received actinium PSMA after 4 cycles, he has got complete response. This is one more case in which lutetium, like post-lutetium PSMA, he is resistant to lutetium PSMA and he had received actinium PSMA with a very good response, and he is on follow-up till 2000. Like this study has been published in 2016, and the patient was alive till 2019. So other published studies, there are very less published studies of actinium PSMA. The one of the good study which has been published is a Krachovan study, which was a German study, in which dosimetric estimate and empirical dose finding, in which around 100 kilobecquerel per kg body weight has been found to be adequate dose, and this is a systematic review and meta-analysis which found which found around six studies has 6 out of total 23 studies, only 6 studies had been used for this systematic review, and they found out it to be increasing in overall survival as well as progressive free survival compared to a second line of chemotherapy, cabazitaxel. So as I told you, this has not been pre-approved. Only lutetium PSMA has been approved, that too last year after several studies of 10 years. So this actinium PSMA is not yet approved. I think it will be approved in the next 1 or 2 years. And currently in use in India as a salvage therapy and unproven interventional clinical practice. It has been used in several institutions throughout India, like in New Delhi and Fortis Gurgaon. Currently, we are also trying to acquire this actinium here. There's one more niche topic in which radio-guided surgery, in which it is a like gallium, like the patients who has been planned for surgery like prostatectomy or extend pelvic lymph node dissection, in which cases when we do scan which showed only 1 or 2 lesions in the pelvis like lymph nodes, these can be tagged with the technetium PSMA, and probe can be used during the surgery to reduce the morbidity. So this is one of the example in which case PSA was around 8. This is 84-year-old male in which PSA was 8 and MRI showed extra prostatic extension and sub-centimeter lymph nodes in the left internal iliac region. So when PSMA PET CT had been done, these 2 lymph nodes in the left pelvic region had shown very good uptake, and those are positive lymph nodes. So what they did is during the surgery, like one day on the day of the surgery, the technetium labeled PSMA had been injected, and using the probe they have removed, like this is a probe counts. If you see this thing 101, so tumor to background ratio they will be taking, the probe counts is being taken, and using the probe only those selective lymph nodes has been dissected, which found out to have cancer cells. So this reduces the morbidity overall. And several studies had been published for radio-guided surgery in prostate cancer, and this showed good concordance of in vivo PSMA detectability with histological analysis of this specimen. Coming to DOTA theranostics, So PSMA, as I told you, it's a membrane antigens. The same goes to DOTA also. So this is somatostatin receptor. So for prostate cancer cells, that PSMA will be there. Whereas for DOTA, like for neuroendocrine tumors, this somatostatin receptor is there in the cancer cell. So we target those somatostatin receptors. There are several types of receptors. So we usually target 2, 3, or 5. So the somatostatin analogs which are used, either gallium and lutetium, or somatostatin DOTA T, DOTA top, DOTA knock. So this summarizes the therapy which we do. So this left side, if you see cancer cells, those are having somatostatin receptors, and the somatostatin analog which is being tagged with lutetium 177. When it touches that somatostatin receptor, they are internalized, and those internalized tissues emits beta rays, and it helps in cell killing. So this is another landmark study which phase 3 trial of lutetium protein for mid-cut neuroendocrine tumor, which showed significant overall survival as well as progression-free survival in these cases. And this is one more study which had. So what happens is, in case of like neuroendocrine tumor can be differentiated in WHO grade 1, 2, 3 based on K6 index. So in case of well differentiated neuroendocrine tumors like grade 1, only DOTA uptake will be there. FTG uptake may not be there. So whereas when you move towards fully differentiation, FTG uptake will be there and DOTA uptake will be minimal. So even in those cases which has significant FTG uptake and poorer DOTA uptake, in which cases of high K6 index, this lutetium DOTA can be used with significant progression-free survival and more median survival. And lutetium DOTA as well as actinium DOTA have the alpha and beta hunting substances theranostics. So actinium DOTA has not yet been approved by FDA and currently used in patients who have poor response to lutetium DOTA therapy and compassionate cases. This is a study which has been published by AIMS New Delhi, in which lutetium DOTA PRRT, when failed, actinium DOTA has been taken, and around 24 patients have been assessed, in which partial remission has been observed in 15, which is significant portion, 70% of cases. Coming to last topic, which is the TARE. So TARE is transarterial radiation embolization. So in which it's a minimally invasive radio-guided surgery, the radio-guided procedure in which radionuclides can be administered through a microcatheter, which is placed in hepatic arterial vasculature. This is to irradiate like liver tumors. So we don't occlude the tumors, we just go there and we inject the radioactive substances. And when it, because they goes to the arterioles and block the small arterioles and keep on emitting radiation, it helps in cell killing. So following the hepatic administration hepatic artery, these radionuclides will be carried preferentially towards the distal arterioles, and these emit high energy radiation into cell death. So indications are current common indications are HCCs, colorectal hepatic metastasis, neuroendocrine hepatic metastasis. So in these cases, what we are preferentially going to downsize the tumors or bridge to transplant. So as a standalone therapy also can be done in case of surgically unresectable tumors or liver dominant metastasis. So if you see if this is BCLC staging stage C, this is where TARE is used in case of multiple metastases in liver, which are not amenable to surgery. We give this radioactive substance so that this can be used for further surgeries or bridge to transplant. So TARE versus SPACE in hepatocellular carcinoma showed significant comparatively compared to TACE, there is a significant quality of life improvement, whereas overall survival is not statistically significant, but number wise it is more. This is one more study which showed like overall and individual patient level meta-analysis, which showed TARE has more quality of life compared to TACE. So in which 17 studies had included, there was no significant difference in overall survival between these two modalities. whereas quality of life is more comparative or taste. Currently, many agents are being used. The most common agent being Yttrium 90 tear. Others includes rhenium or iodine 123 liquidol, 131 liquidol. So these agents, this is one more AIM study which has been published, which compared the rhenium labradol versus yttrium 90 spears. So there is no significant difference in treatment related responses in these two patients, these two categories. So the procedure is two-stage procedure in which first stage we will be doing all of the lab investigations and technician labeled MA shunt. So MA shunt tells us like what is the treatment area and whether there is any significant shunt between liver and lung. So if there is a shunt between liver and lung, based on how much percentage of shunt, we will be reducing the dose of therapy. So this technetium labeled MA can be used for radiation dosimetry by using these methods. So we calculate the appropriate dose of radionuclide which has to be delivered during the second stage procedure, which can be either yttrium 90 tear or 188 rhenium tear. So the same way as the first stage procedure will be going to the hepatic artery and super selectively will be giving this radioactive substance which goes and embolizes the arterioles nearby the tumor cells and emits radiation and kills the cancer cells. So post the procedure, we will be doing yttrium 90 PET CT, and we compare it usually with the pre-treatment PET CT so that the tumor volume, how much tumor volume it has been taken up, is there any deficit in the tumor volume or excess volume of normal hepatic tissue has been absorbed by this radionuclide, because when there is excess absorption, so we expect more of side effects. So the most common side effects are fatigue, abdominal pain, nausea, fever, and transient increase in transaminases. And other severe side effects are chronic abdominal pain or radiation-induced liver diseases, in which hepatitis can be there, decompensation can be there, and radiation necrosis of segment and rupture also can be there, which leads to liver failure. So coming to conclusions, so the radioactive traces helps in diagnosis as well as treat diseases. So the most common ones which we use for diagnosis are gamma emitting and positron emitting substances, whereas for treatment it is beta emitting and alpha emitting substances. So theranostics refers to the pairing of these diagnostic biomarkers with therapeutic agents that share a specific target in disease cells or tissues. And as I discussed, bone pain palliation and how, like where in WHO pain lacquer it comes, and what are the traces which are used, and more specific theranostic approaches like PSMA, Dotanov, Dotatate, or TERE, or upcoming role in radioguided surgery. This concludes my session. If you have any queries, please. Thank you. So FAPI is FAPI is one more molecule which has been recently approved, like not approved, recently discovered for diagnosis as well as therapy. So So FAPI is fibroblast associated protein inhibitor. So tumor cells has a tumor has a tumor cell as well as protein matrix in surrounding tissues. So in those matrix, fibroblasts will be there. So those tumor fibroblasts are targeted to using this FAP molecules. So these can be used for both diagnosis as well as therapy, as mentioned. Gallium FAPI for diagnosis and lutetium and actinium FAPI for therapy. Several studies are being done currently, which is yet to get published, but they showed very good responses because in those tumors which are not unable to lutetium PSMA, you can do FAPI studies, and if there is FAPI uptake, you can do FAPI therapy also. One more thing is any malignancy. So this bone pain palliation can be done for any any malignancy with sclerotic bone metastasis.
सर आप everyone पर टाइप कीजिए सर, not with the private.
What? Everyone, 1 second.
हाँ सर, chat with everyone select कीजिए सर.
Okay. Done. Thanks.
ओरली रिप्लाई करने की कोशिश कीजिए सर.
Yes.
सर आप just try to reply the query in orally sir. Don't type.
Oh, okay. Sorry. Yeah.
Orally.
Yeah. I think almost all the done. All of them were done.
Okay sir.
Yeah. Yes, I will be sharing the PPT with the MBE board. You can get this. I believe.
Yes sir. Thank you sir.
Thank you.
And
Yeah,
thanks.
thank you. So, where should I send this PPT?
Sir, I'll send you sir on the chat. I'll email you my mail ID sir. Our official mail ID.
Sure.
Thank you sir.
Thank you.